Kemp's test for lumbar facet joint pain. What's its value? What do you call it? Kemp's test? Quadrant test? Extension rotation test? You might be surprised to find out that there are no actual studies for Kemp's test. There are studies for extension rotation testing for facet pain, but how these tests are performed and what is considered a positive response is far from standard. It's common for all of us to use what is taught in our formal education or use whatever is listed as part of a group of orthopedic tests for a given area on a form by an insurance company, managed care company, or chiropractic college. But what do we know about the value of that test? In a recent survey of Ontario chiropractors, they stated that they, quote, often or almost always, unquote, use the Kemp's test as a diagnostic procedure for facet pain. The relative percentages per region were for the cervical spine 82.4%, thoracic spine 69.8%, and the lumbar spine 82.2%. And a multidisciplinary panel of experts consisting of physicians, surgeons, and physical therapists based in Australia and New Zealand were asked to identify indicators of facet joint pain. One of the items that achieved consensus was, quote, pain in extension, lateral flexion, or rotation to the ipsilateral side, unquote. And although a survey at the 2008 Annual Congress of the European Chiropractors Union indicated that a majority of those in attendance agreed that a positive Kemp's test would aid in diagnosing facet syndrome, a recent survey of faculty members at an American chiropractic college indicated that nearly half of the respondents disagreed with the statements, quote, a positive Kemp's test is a strong indicator that facet syndrome is present, and a negative Kemp's test is a strong indicator that facet syndrome is not present, unquote. Why the disparity? Well, 41.5% of respondents considered a positive Kemp's test to be a strong indicator of the presence of a lateral disc lesion, compared to only 26.8% who considered it to be a strong indicator of facet syndrome. So clearly, there is quite a bit of complexity to the understanding of how the Kemp's test is studied, utilized, and interpreted, and also how this test and its findings relate in any way to predicting who will respond to manipulation. Although implicit, it would seem that given manipulation has its mechanical effect at the facet joint, chiropractors do likely use this test as a subluxation finder. A study published in 2014 in the Journal of the Canadian Chiropractic Association attempts to review what is known about the Kemp's test in The Diagnostic Accuracy of the Kemp's Test, a systematic review. The search was for articles that used an extension rotation test as part of the evaluation for possible facet joint pain. The identified study would then need to use a single or double nerve root block to eliminate or partially eliminate the patient's pain. Unfortunately, this aspect was clouded by the fact that some patients were tested post-injection, while others were only considered positive for facet joint pain with relief on injection. That relief only had to be for a limited time. So how many articles qualified? Only 5. None called the test Kemp's test or quadrant test. All studies referred to the test as extension rotation test. Also, none were found for the cervical spine. All were lumbar facet studies. Even with this limited number, the researchers found that most had methodological flaws, such as a high degree of bias. Remember before we continue that the innervation of deep spinal structures and facets is divided into 2 main nerves. The deepest structures are innervated by the sinovertebral nerves, such as parts of the annular fiber, anterior dura, and posterior longitudinal ligament, whereas the facet joints and deep ligaments and muscles are innervated by the medial branch of the posterior primary rami, with some overlap across several joints. The concern that has been expressed is that single diagnostic blocks used as a gold standard result in high false positive rates ranging from 27 to 63%, so many studies use a protocol of 2 injections. Of the 5 studies, 3 studies applied double block injections as the reference standard. The remaining 2 studies used a single block injection. The authors qualified a positive result as the absence of pain exacerbation on extension rotation. There were some interesting findings. Although none of the included studies had both sensitivity and specificity measures of at least 50% for the extension rotation tests, Two studies demonstrated 100% sensitivity using 95% pain relief on injection and 85% sensitivity using 75% pain relief. However, the highest positive likelihood ratio was only 1.29, the lowest negative likelihood ratio was 0, and the best positive predictive value was 43.5%, and the highest negative predictive value was around 100%. But sensitivity values averaged across studies were less than 50%, and the average negative predictive value was approximately 60%. A major flaw with comparisons among studies is how the test is performed. Is it performed seated or standing? Well, most studies seem to have the patient stand. Most seemed also to use an active test rather than the examiner passively hyperextending the patient. One of the studies used it as part of the McKinsey approach of testing, and because of this, we're looking more for a centralization or peripheralization response. Even more confusing was that the researchers found two studies where pain exacerbated by extension rotation indicated treatment failure for patients who had a positive response to a single facet block and underwent radiofrequency denervation. The researchers' conclusion, quote, currently the literature supporting the use of the Kemp's test is limited and indicates that it has poor diagnostic accuracy. It is debatable whether clinicians should continue to use this test to diagnose facet joint pain, unquote. So do we simply stop using Kemp's? Well, that depends on its purpose. If we're using Kemp's for determining who goes onto facet injection, it may not be helpful given a trial of manipulation would likely precede such a referral. Yet one study examined whether extension rotation might be part of a clinical prediction rule to determine who not to send, given facet joint blocks do not always provide relief. The title is Clinical Predictors of Screening Lumbar Zygapophyseal Joint Blocks, Development of Clinical Prediction Rules, published in the Spine Journal in 2006. They arrived at the following predictive variables: age greater than 50, symptoms best with walking, symptoms best with sitting, onset pain is paraspinal, positive extension rotation test, modified somatic perception questionnaire score greater than 13, and absence of centralization. Their clinical prediction rule indicated that for a patient with low back pain, facet joint block is indicated if 4 or more predictive variables are present with a positive likelihood ratio of 7.6 and a negative likelihood ratio of 0 if less than 4 variables are present. In a previous presentation, we reviewed cervical facet diagnosis in an article entitled Derivation of a Clinical Decision Guide in the Diagnosis of Cervical Facet Joint Pain, published in Archives of Physical Medicine and Rehabilitation in 2014. They tested palpation for segmental tenderness, the extension rotation test, and the manual spinal exam. For the manual spinal exam, patients were prone and the examiner directed posterior to anterior pressure at the articular pillars of each segmental level performed on both the right and left sides. When moderate or marked restriction was noted with an associated increase in pain, local or referred, the test was considered positive. Testing positive on all 3 clinical tests of segmental tenderness, extension rotation, and manual spinal exam, the likelihood ratio was 4.94, and the post-test probability of a diagnosis of facet joint pain increased from 42 to 78%. If testing negative on the palpation for segmental tenderness, the negative likelihood ratio was 0.08, and the post-test probability of a diagnosis of facet joint pain decreased to 5%. So the researchers suggested that potential screening tests prior to referring a patient for cervical facet joint blocks include the manual spinal exam and palpation for segmental tenderness due to their high sensitivity and low likelihood ratio. The lowest likelihood ratio was associated with the palpation for segmental tenderness test. So let's add all of this together to come up with an approach. If the findings of this review are true with regard to the lack of value for the Kemp's tests, yet it seems to have some value as a cluster for predicting those with facet joint pain relief by injection, perhaps we can continue to use but not rely solely on this test to rule in or rule out facet joint pain. But we have another opportunity in our practices. Given we already likely use Kemp's as part of our exam, Wouldn't it make more sense to test its value in our own practice? How? Create a spreadsheet of all new patients who come in with low back pain. Have columns for exam tests and enter a number 1 in each that is positive. Also, have a column with the working diagnosis and whether manipulation was used in treatment. Now, all that's needed is to keep entering this data on the next 100 or so low back pain patients. By sorting, you can see if this test or any other tests you use are positive or negative in a given patient and sort by that and then the diagnosis. Finally, determine if manipulation helped or did not help that patient. Scientific? Well, partly because it is in your practice, it can help you determining the value of tests in your environment and context. So let's look at a hypothetical example using sorting. Sorting by Kemp's test positives, we can see several things. We can see how many responded to manipulation and whether the patient had radiation as part of the complaint. And finally, what other tests were positive. Compare this to those with a diagnosis of disc lesion. Here we see that Kemp's test was positive equally between the two diagnoses. However, those with a facet diagnosis and a positive Kemp's had a positive response to manipulation, whereas those with a disc lesion diagnosis did not. Again, this is a hypothetical example. Other possibilities are likely, but what it would reflect is the relationship to how Kemp's test performed in your practice relates to a diagnosis and as a predictor of treatment success with manipulation, how you perform manipulation. Although this does not allow extrapolation to other clinical environments, it represents yours. Now let's do some dreaming. What if all the chiropractors in your local area did the same thing? What an interesting discussion at your next society meeting. This would be the seed for a best practices project and inevitably better patient care. Now, what if this happened nationally and then internationally, and not just for Kemp's test, but for all orthopedic testing typically used in practice?